Okay, we're going to get started. Those of you who are here, thank you for, again, coming on time. Thank you for coming. We're very excited that we're all here tonight. This is a first for us here at Touro. My name is Eric Wax. I am the Director of Oral and Maxillofacial Surgery, and I am the Chair of our Continuing Education Committee. We have a fairly robust CE program that we've been working on and developing and expanding. So we have lots planned for the future, and you'll all hear about it. Tonight is our first venture into the world of sleep and orofacial pain. We have a great guest speaker tonight who I think you'll really enjoy hearing from. And we have big plans to expand our offerings in this area in the future, which you'll hear about shortly. I'm going to hand things off to Lauren Levy. Dr. Levy is our Director of Orofacial Pain and Sleep here at Touro. She sees patients at school, teaches our students, teaches our residents, and has a vast amount of experience in these fields. So I'm going to hand off to her to tell us a little more about our speaker, and then we'll get started. Again, thanks for coming, and we hope to see you all in the future.
Thank you. So yeah, we are very excited to welcome Dr. Jamison Spencer here. He is the Director of the Centers for Sleep Apnea and TMJ in Boise, Idaho, and Salt Lake City, Utah. And he has treated thousands of patients with sleep apnea and TMD, and now focuses on helping dentists help their patients with such problems. He has numerous titles. He's the past president of the American Academy of Craniofacial Pain. He's a diplomat of the American Board of Craniofacial Pain, a diplomat of the American Board of Dental Sleep Medicine, a diplomat of the American Board of Craniofacial Dental Sleep Medicine, and has a master's in craniofacial pain from Tufts University. In addition to all of this, he's taught head and neck anatomy at Boise State University, and he's adjunct faculty at the University of Utah School of Dental Medicine. He has given lectures in many locations, and he's spoken on TMD, dental sleep medicine, and head and neck anatomy throughout the United States at every major dental meeting, and has also spoken internationally in Canada, Central and South America, the Caribbean, Australia, Europe, and India. He also created something called Spencer Study Club, an online education, mentoring, and implementation program to help dentists and their teams help more of their patients with sleep apnea and TMD. And currently he lives in Utah with his wife of 33 years and their children, and he enjoys outdoor activities such as running, skiing, water skiing, kiteboarding, mountain biking, and he would have been at the Boston Marathon in 2010 had it not been canceled. So,
before Dr. Spencer starts, I just want to add a couple of things. You can get CE for tonight's lecture. In order to get the CE, you do need to complete the evaluation that will be available after the lecture. And if you have questions along the way, please submit them to the Q&A at the bottom of your screen. Dr. Levy and myself and Dr. Mansdorf, also in our pain and sleep department, will be monitoring the questions. We will ask Dr. Spencer questions that we need to ask in a timely fashion, and some of the questions, depending on how they fit, we may save for the end, but we'll try to get to everybody. So sit back, enjoy the lecture, and feel free to ask us some questions along the way. Dr. Spencer, it's up to you.
All right, well, thank you very much. And just a second here, as happens all the time, we had everything set up, and then when I go to share, it doesn't. So let's do that really quick. So thanks all of you for having me here. It's a real honor to be with you tonight and to have this kind of first meeting here for Touro and to help them with their CE getting set up. So our lecture for tonight, our title for our lecture, Parafunction or Protective Function. And we're going to talk about the possible connection between bruxism and obstructive sleep apnea. So I scoured the internet and I wanted to try to find an image of bruxism that would just shock you and horrify you. And so here it is. Probably none of you have ever seen some bruxism like this, I assume, in your clinical practice. Okay, clearly that's a joke. I'm sure that you saw multiple people today with this level of bruxism. And one question to kind of start off and get our thinking going here, our thinking juices flowing. Have you ever wondered why people come out on their front teeth like that? Wear down the enamel on their front teeth? And we'll talk about this in a minute, but oftentimes when you ask people if they're aware of this behavior, they're not really sure that they are. They will say, well, they don't do that, even though you can see this wear. So that's what we're going to talk about a little bit tonight. Now, parafunction is a dental thing, and it's defined as physical behavior without functional purpose. And again, this is a dental thing. There's no parafunction of my shoulder, for example, but we attribute this parafunction to all sorts of things in dentistry, all sorts of things that parafunction might lead to, and that we blame these things on this so-called parafunction. For example, damage to the teeth, damage to the restorations. We have spent much time and energy and focus in dentistry on trying to create dental materials that are less apt to fracture. Several years ago, zirconia was developed for dental use, and now we have bruxism crowns and other zirconia crowns that are basically indestructible. I asked actually Gordon Christensen a question about this the other day. He and I are friends, and I said, so Gordon, now that we have materials that are indestructible, does that mean that people have stopped trying to break things? And of course, as you would imagine, he said, well, no. And we had a nice discussion on, I wonder where these forces go now. The forces that used to do what you're seeing on the screen that now are pitted against zirconia type materials that are indestructible, or implants that are osteointegrated and aren't going anywhere, unlike a PDL. I wonder where those forces go. We blame TMJ problems, muscle pain, reducing disc displacements, non-reducing disc displacement, degenerative joint disease. We will tend to say that all of these things are related to a patient's parafunction. That perhaps if they didn't have that parafunction, then maybe they wouldn't have developed these TMJ problems, this muscle pain, these various disorders. Myofascial pain, where there's trigger points in the muscles, and this then refers pain into the teeth and other areas of the head and neck, can be very confusing for us as dentists as we have these patients present complaining of tooth pain, but the pain isn't actually coming from their teeth, it's coming from their muscles. And again, we will typically blame such things on this parafunction. But what if it isn't parafunction? So here's what I'd like you to consider is a paradigm shift about the etiology of these different things. And this is a word I made up. I'm fond of making up terms and words. And the term that I developed, I call protective function. And that is intended to be a play on parafunction, but instead protective function. And this I defined as physical behavior that's intended, whether conscious or subconscious, to improve survival. So here's the idea in a nutshell, is that maybe some people clench or grind their teeth or just posture their jaw in a way to try to protect their airway so they don't die. Now let me say that again. Perhaps some people, please note I'm not saying all people, may clench or grind their teeth or just posture their jaw. Note that I'm not saying that it even involves tooth contact all the time. But that perhaps some people are doing this behavior to try to protect their airway so they don't die. So we're going to get into some details and some of the science on this, and this is the case I'm going to try to make. And it looks like someone's already put something in the Q&A box, and so that's good, because I may ask you. As a matter of fact, I think I'll ask you a question here in just a minute. So Before we get into talking about bruxism, though, let me share with you a clinical pearl. So let's see if this Q&A box is working here and if I can see your responses. So how many of you ask your patients on a regular basis, do you clench or grind your teeth? Go ahead and put into the Q&A there, yes, I do, or no, I never do, or whatever, and we'll see what happens. I'm not sure if this will work or not. Usually I use the chat feature for this, but it seems to be working. Okay, let me pop up the Q&A. Awesome, it is working. Thank you, John, Gail, Charlene, Nardine. Thank you so much for putting this in. Anonymous, good job, Anonymous. I love your name. Another Anonymous. Gary Lauder, is that Gary Lauder from Salt Lake? Okay, Gary Lauder, you got to put in if that's my good friend Gary Lauder. If Touro University has that big of a reach that it's getting to my friend Gary Lauder from Salt. Oh my gosh, Gary. Well, welcome. This is not limited to the greater New York area. All right, awesome. So almost all of you do this on a regular basis. You're asking your patients, do your clench or grind your teeth. Now, I won't ask this next one because I'm pretty sure that you're going to be gelling with me here. So you ask, do you clench or grind your teeth? And then what do they say? They say, me, of course not. And then you say, yes, you do, I can tell. And now we have a fight. Now we have a fight on our hands because I've asked, do you? And they've said, no, so I got nowhere to go. So here's the clinical pearl I'd like you to consider. For the rest of your career, do me a favor and ask, are you aware of clenching or grinding your teeth? Are you aware? Instead of do you. Again, if you say, do you? And they say no, then you're done. If you say, are you aware? And they say no, then you might say, you know what? I think you might, or you have in the past. Let me show you why I say that. And since the dawn of intraoral cameras, and now with scanning, this has become really easy to show them. You can scan their teeth, you can put it up on a big monitor, huge. As a matter of fact, nowadays, you can use those scans and even do them serial scans and show if there's wear actively going on. Which is why, by the way, on that point of actively going on, I have on this slide, or you have in the past, all caps. Because does wear on the teeth mean current behavior? Not necessarily, right? So just because I've got that anterior wear, just because I've got my canines worn down, that doesn't mean that right now I'm a lateral bruxer or an anterior grinder, right? It just means at some point in the past. And this is the beauty of this method, is they will get on your side there. So if you say, are you aware of clenching around your teeth? And they say, no, I'm not. You say, you know what? I think you might, or maybe you did in the past. They'll say, well, you know what? Yeah, you're probably right. Back in college, I was under some stress and you know what? I bet that's it. I bet that is when I wore down 3 millimeters of tooth structure there. That last part was my joke there of probably that's not the case, right? But at least they will then be on the same side of you to then have you show them what you're talking about. And I liken this to if you were to take your car in for an oil change, let's say, and they had it on the lift and they say, hey, doctor, come here. And you're like, what's going on? You're like, hey, I need to show you what's going on with your right front tire. And you're like, okay. And they show you, say, you see here on the inside of the tire, it's worn all weird. You can see the belts on that inside. You can't see this from the outside, but on that inside edge, it's worn really strange. Were you aware of that? And you'd be like, well, no, I had no clue, right? And then they would offer to repair it. But any reasonable person would say, well, what caused that? What do we need to do so that doesn't happen again? That part right there, and that's an analogy you can use with your patients, by the way. I don't know that most people know to ask that about their teeth because they're just their teeth. They're the only experience with teeth they have. They're not like us weirdos that look at people's teeth on a regular basis. So they don't know what is normal and what is abnormal. They wouldn't know that worn canines is not necessarily normal. They wouldn't know that seeing that inside dentin part of their lower anteriors isn't normal, because that's just what their teeth look like. Maybe their dad's teeth look like that too, they remember. So they would just assume that's normal. So I think it's our job to make them aware of abnormal, and then to go to the next step of, what do you think caused this? What could we do to avoid this wear down the road? Okay, so that's our clinical pearl, is stop asking, do you? Go to, are you aware of? And then once you go to, are you aware of? Then you can take them down this path. That will literally change your life. If you literally have been asking, do you clench or grind your teeth? And your staff, your hygienist too, they're asking that same question. If you just change it to, are you aware of? It will literally change your life as a dentist. I know that seems like hyperbole, but I promise it will. So that kind of begs the question, how much time should we spend with our teeth in contact, right? So we're talking about wear and, do you clench or grind and stuff like that. So maybe we should get on the same page here with how much time should we actually have our teeth in contact? Back to the Q&A, please. So in the Q&A, would you put...
We have a question in the Q&A before you add yours, because I won't
go ahead.
keep track of it. If the patient is young and does not have signs of bruxism, no signs of bruxism are yet shown, how long will it take till bruxism can cause teeth to wear?
I don't know. I'm not sure that do any of the panelists know that? So
I do not.
I think that John Coyce, I believe, did some research, and he said that it takes, with normal attrition of the teeth. So someone can put in the Q&A if they actually know this reference, and I apologize, I don't have it in my lecture, but I have heard that John Coyce, who's a very smart guy, if you guys know him, that he says normal attrition is 1 millimeter per 100 years. Which I love that quote, if that's real. I don't know if that's apocryphal or not. I need to ask Dr. Coyce if that's true that he said that. But I've had multiple people tell me he said that. If that's true, I've used that actually and said, hey, a big deal, in our field says it's 1 millimeter per 100 years. And you, patient, are looking pretty good because based on your tooth wear, you're about 320 years old. Okay, so so if somebody knows the actual reference, put it in the Q&A for all of our edification here. But now, back to this. Any other questions on that? Are we good? Move forward? And
That's it for now. Yep, we're good.
And I can't see any of you, by the way, so thank you for chiming in on that, because that's the only way I'll know to stop or slow down here. All right, so back in the Q&A, put in how much time in a 24-hour period we should spend with our teeth in contact. So how many minutes, hours, seconds, whatever you think, put that in the Q&A, and I'm going to open that up so I can see your answers. Okay, so everybody back to the Q&A, and you're going to put in how long in a 24-hour period our teeth should be in contact. All right, Jocelyn says 2 hours, Willie says 10 minutes, Charlene says 45 minutes, Shamon says 30% of the time. So that would be what? That'd be 8 hours, if I'm doing my math right there. An hour, 20 minutes, 2 hours, 3 hours, 2 hours, 5 minutes, 2 hours, 17 to 21. 3, says John. That could be 3 hours. That could be 3 minutes. Could be 3 seconds. So John could be hitting a lot of different things there. Haley, less than 3 hours, just during eating. Depends on my wife. Excellent. Great answer. When swallowing, 2 hours. All right, cool. So first of all, this should slightly disturb us, okay? Because I assume that dang near everybody on this webinar right now is a dentist. Does that seem weird to you that none of us know the answer to this question? That we just kind of have feelings, and that this goes from, I think our lowest there was 5 minutes, and our highest was 8 hours in that small sampling of dentists here. That bugs me a little bit, that we're just kind of like, I don't know. And so this next thing here, I call this 1% occlusion, and I hope to be known someday. This is how weird I am. This is one of my goals in life, is I'd like to be known as the 1% occlusion guy. the 1% occlusion guy. And I've been teaching this principle for a long time, that I think our teeth should touch very little, as in 1% of the day. And 99% of the time, they shouldn't be in contact. And I was teaching this principle once at a course that I taught for the US Army dentists. And it was at Fort Gordon, if I remember correctly. And if any of you were in the Army, you know that in the Army residencies, they have journals. So they have the Journal of Prosthetic Dentistry and the Glossary of Prosthetic Dentistry, and they have Dental Clinics in North America, and they have all these journals, and they go back forever, like to the 50s and 40s, and they have them there physically in the clinic. And this one time I'm teaching and I mention this and I say out loud, hey, you know, I've been looking all over the place for the research on this and I can't find anything. I've searched, you know, NIH.gov. I cannot find anything on this. And one of the colonels who'd been in my presentation before stands up and he leaves. And I figured, oh, he's got something to do. And he's gone for a while. And then he comes back about 15 minutes later and he's got a bunch of papers in his hands. And well, it turns out that those papers was a research study that he somehow, with his photographic memory, remembered was in the Dental Clinics of North America in 1969. And so he came and gave me this study from Professor Graff, who is well known in bruxism and centric relation, the area of these things. And so here we go. So my 1% occlusion that I just kind of pulled out of the air does have a little bit of evidence to support it. 1% of 24 hours is 15 minutes. So this is pretty close. 17 and a half minutes is calculation of total time during 24 hours, direct occlusal force, application to periodontal tissues. So this is enough touching of your teeth that it would actually give force to your periodontal tissues, okay? All right, so let's break down this 17 and a half minutes. So as many of you said, chewing and swallowing is a big part of this. Chewing is the biggest part, so 9 minutes. This is based on 4 meals a day, and I'm gonna come back to this in a second, but 4 meals a day, 9 minutes of chewing time with teeth contact. Swallowing during meals may surprise you. It's only about half a minute, only about 30 seconds is all that our tooth contact cumulative with that 4 meals a day would only be 30 seconds. Amazing. Okay, next, between meals, so 25 times per hour during the day we swallow, and then during sleep we only swallow 10 times per hour. Why so much less during sleep? Well, because we don't produce saliva at the same rate during sleep. So that kind of begs a question here, because that's only 1.3 minutes of tooth contact time during 8 hours of sleep. So one may wonder, what's your night guard doing the other 7 hours and 58 minutes? Well, I think it's kind of doing an impression of a retainer, if you get my joke there. So in other words, if the teeth aren't touching the night guard, what's the night guard doing? It's just hanging out. So if you use an upper night guard, it's just sit on the upper teeth. It's being an upper retainer. So this 1% occlusion is kind of a big deal. Now, let me go a little deeper here and say that maybe in 2024, it's not even 1%, because this is 4 meals a day back in 1969. What has changed with regard to our diet since 1969? Well, one may say, well, there'd be less smoking involved. But that's not what I was going for. What I was going for is real food back in 1969, right? I mean, they were eating like real stuff that would probably require tooth contact. I'm pretty sure that in 2024, you could live your whole life and basically never touch your teeth together if you didn't want to. Chicken McNuggets do not require tooth contact. The goop that comes in little packages now that we give the little kids, Gerber baby food was invented right around this time, okay? Late 60s, early 70s. All the soft processed foods have been invented since then, for the most part. So I would propose to you that maybe even we put our teeth together less, depending on who you are and your diet. Nevertheless, we'll go ahead and use this as our standard, if you will, that a normal person is going to have their teeth in contact about 15 minutes per day. So again, what I call 1% occlusion. And we all know intuitively, and there's also a lot of research on this. I just pulled one random study from quite a while ago, but we do know that people, or we believe anyway, that people with temporomandibular disorders spend a lot more time with their teeth together. Now, with this 1% occlusion thing, though, this takes on a different meaning, because 3 to 6 times more non-functional tooth contact, if you think, well, 1% occlusion, 15 minutes, so 3 to 6 times that would be 45 minutes to an hour and a half. And let me use an analogy on that. So as Lauren mentioned, I'm a bit of a runner. I'm not running as much anymore, but a few years ago, I qualified for the Boston Marathon 2 or 3 times, and then finally made it in. And then it was canceled because there's this COVID thing that happened. You might have heard about it. And let's say that it's only what, 7:25, 7:27 on the East Coast. So let's say that after this webinar, we're all going to go on a run together, okay? And probably almost all of you watching this could run for 15 minutes and live to see tomorrow. But I think the herd would get cold a little bit if we took that to a 45-minute run. Okay. Only those who run on a regular basis are going to be able to comfortably run for 45 minutes. And then if we took that to an hour and a half, there's going to be a lot less people able to do that. And even the people who push through it and run for an hour and a half, they're going to be pretty darn sore tomorrow. So think about that. That 3 to 6 times, it doesn't mean that the person is clenching their teeth all the time. As a matter of fact, here's something a little weird with TMJ disorders and the muscles of mastication and bruxism. Let's do something together here really quick, and we'll go back to this bruxism thing. So everybody at home, play a little game with me. I want you to clench your teeth as hard as you can and move your jaw side to side without relaxing your clench. Go ahead and do it. Clench your teeth as hard as you can and move your jaw side to side, but don't relax your clench. Okay, now I can't see you at home, but if you're doing that at home, so you can relax now, you didn't move side to side. And you'll say, well, yeah, that's because the teeth were in the way. But I propose to you that you could put a pen between your teeth. You could do this in the office tomorrow with a tongue depressor. You can put anything you want between your teeth. And if you are truly clenching as hard as you can, you will not be able to move your jaw side to side. Why not? Because we have the temporalis, the masseter, and the medial pterygoid, all as elevators going, "Arr!" And then you have the little lateral pterygoid going, trying to move our jaw side to side. It's like fighting my thigh with my pinky. You know, my pinky's not going to win that fight. So here's the take-home message. In order to be a grinder, you have to relax to a degree your elevator muscles. So people who are grinders in general don't have as much muscle pain. Clenchers will have more muscle pain because they're able to recruit so many more motor units. But here's another oddity. Here's another odd. Let me finish this point, then I'll take the question. Yeah. The other oddity is I use the running analogy. So if any of you are on this call right now who are runners and like marathoners and stuff, an hour and a half run for you is nothing. It's no big deal. When I was training for marathons to go out and do 12 to 16 miles, I just called that Saturday. That was no big deal, right? Now, if I was to go out and run for 8 miles, I would feel it a lot. So here's the take-home message here. People who do spend a lot of time with their teeth together don't tend to hurt because they are trained athletes. They are trained clencher athletes. They are trained bruxer athletes. And so you can have these people in your practice with these huge masseters and they don't hurt because they're trained athletes. Go ahead and ask a question.
So we have 2 questions for you. One, when you were talking about someone having a mouth guard in, doesn't it depend on the design or the fabrication of the mouth guard? For instance, if the guard impinges on the freeway space, how will that change things?
Well, that could actually. So if the mouth guard was so thick that their teeth had no choice but to kind of rest on it. And if all of you do this, you can have an appliance between your teeth or put something between your teeth. And for most of us, if our teeth, like you can do this at home right now, if you palpate your masseters and then just barely put your teeth together and see how much force it takes to activate that muscle. And most of you will notice, not all of you, but most of you will notice that if you just barely touch your teeth together, you kind of activate that masseter muscle. So I think you're correct that if someone put in a big thick guard that violated that freeway space, as we call it, then the person would have a tendency to, quote, rest on it. And if that did rest on it for many of us, myself included, if I was resting, that would activate those muscles more so than it normally would.
Thank you. And one more question. You mentioned the study. Someone asked if the study was ever repeated, looking at the average time of teeth contact during the day, or is there any talk of looking at that again to seeing how it's changed?
I don't know. So like I said, until that was pointed out to me, I'd looked all over the place. So I'd love, I'll throw that to Lauren and Asher and the smart people there to put some grad student on that. have them do a deeper dive and figure out, because that seems very unlikely that, one time we would have looked at this. But on the other hand, clearly this is not something that we're taught. This is not a national board question. This is not something that we're on the same page about at every dental school in the country, because I give this lecture, 30 times a year or 40 times a year, and it's always all over the board. I will get everywhere from no one did it this time, but I'll usually have dentists that say our teeth should never touch. And then my comeback to that is, well, why did they make me do a Lundin wax up in dental school then? Why did they make me study occlusion so much if the teeth are never supposed to touch? That makes no sense. And then I'll have a weirdo every once in a while say, oh, the teeth should always be touching. And then again, when I'm in a live lecture, everyone in the room will look at that dentist and go, dude, who are you? That's ridiculous. Of course our teeth shouldn't touch all the time. But that's a dentist too. So that's kind of a weird thing to me there, is that we don't, that seems like that would be something that every dentist in the world would be like, yep, this is average, or this is normal, and then some variance of that. So, I'm not saying that all of us should be 1% occluders per se, but I think when people start getting out of that realm of their normal occlusion, that's when they start to have pain.
Two more quick questions, then I'll let you continue, even if we get more. One, can you clarify when saying TMD, does it mean muscle problem or joint problem? How can you define TMD?
Both. So temporomandibular disorders are a big umbrella term. So when I am referring to that, and in the literature, that's why the literature in temporomandibular disorders mostly sucks, is because of stuff like that. They'll use terms like TMD, and then that could be myalgia, it could be myofascial pain, it could be a reducing displacement, it could be a non-reducing displacement, it could be an arthritic joint, it could be whatever, and it's all lumped under temporomandibular disorders. So for the purposes of this lecture or this webinar, when I say TMD, I'm using that as an umbrella term.
Great, that clarifies for everybody. And last question for now, do weightlifters not suffer from TMD?
I'm not sure they do. So I have seen a few trained athletes of that level in my career, but a few. I can literally count on a hand or two. And if anyone, maybe the person who asked that question knows this, maybe you don't. But there's a thing now, it's called the Jawzerciser. If you don't know what that is, YouTube it. It's ridiculous. So it's this big old piece of plastic, basically, that these meatheads in the gyms are biting on in order to make their masseters bigger and basically their jaw muscles bigger to sculpt their jaw. And there's also now exceedingly hard gum that is for sale. And so you would imagine that if those things themselves were causing major problems, that those companies would be out of business by now. And so far they aren't. So I have a theory that just kind of goes with musculoskeletal. That sometimes we treat this jaw. The jaw is is unique. The only joints in the body that rotate and articulate, and then we have two joints connected by one bone, and that bone and this bone have teeth that articulate. Okay, that's a crazy complicated system. I get that. But on the other hand, it does still follow physiology. So when the jaw joint and muscular system have an issue, it's similar to issues in knees, hips, shoulders, the other joints and muscular systems that we have. It's not that unique. Okay, all right, moving on. So here's two more take-home thing, or one more really take-home thing. The other one's just for fun. But lips together, teeth apart. In addition to, are you aware of clenching and grinding your teeth? This will change your life and your patient's life the biggest, and that is lips together, teeth apart. This is something that must be said in our practices in Boise and Salt Lake City, I don't know, 100 times a day. Lips together, teeth apart. We want our patients lips together, teeth apart. And that is to train them that their teeth should not be touching all the time, and that if they are noticing that, then they should do something about it. Or for our prosthodontists in the group here, the VD no. I know you're familiar with the VDO. I want you to think about the VD no, which is the vertical dimension of non-occlusion, or what Posselt might have described as the rest position. This is something we don't think about enough, is that rest position, teeth apart, which happens before we go into centric and stuff like that. All right, back to our main story here, nocturnal bruxism. So I'll speed through this a bit, and then we can take questions at the very end if you'd like. So sleep bruxism muscle activity is associated with a rise in respiration within arousal. In that study, they showed that the person would breathe deeper after a bruxism episode. Weird. In this study, this second one here, they were looking for where are these signals coming from that are eliciting the bruxism event. And they found that they were coming from the brainstem. What's the brainstem's job? Isn't the brainstem's job keeping us alive? Why would the brainstem be involved with bruxism? This is one of my favorite studies right here, 1986. And I put this in here to show that this has been looked at for a long time. This isn't just some new fad. I was in high school when Jeff Okeson looked at this in 1986. Many of those on the webinar right now were not even born yet. Okay, so this is not just some new fad. So in 1986, Jeff Okeson and his group looked at clenching, and they found that people were more likely to clench their teeth laying on their back versus their side. So their obstructive sleep apnea would be worse on the back, and their clenching would be worse on their back. This study was basically repeated in 2003, found 74% of the rhythmic maxillary muscle activity was scored on the back, 23% on your side. So why do people clench and grind their teeth? If we went and asked 100 people just off the street randomly why people clench and grind their teeth, they're all going to say the same thing, and that is stress. Here's a zebra. He thinks it's stress. This dude's got espresso concentrate going to his veins. He's so stressed. This guy's got a headache. Here's your office manager after you've done something stupid for the 50th time, and I think we can all agree that this dog looks stressed. However, have any of you ever choked on some food? Like you actually got some food down the wrong pipe and you were choking, no sound, no air coming out. Someone had to come and Heimlich you. I bet if you've ever had that experience, that while you were choking, you weren't thinking to yourself, wait a second, did I shut my garage door when I left the house? No, I bet you weren't thinking, did I turn off the iron when I left this morning? No, you're thinking, I'm about to die. You're thinking, I hope someone helps me really quick because I am about to die. If you've ever been underwater and you weren't sure you're going to get to the surface, you weren't concerned about, a pending tax bill. You were concerned about getting to the surface. If any of you have ever had your wife try to kill you with a plastic bag like mine will do from time to time, all right, maybe I lost you on that one. But here's my point. Is for years and years and years, we've blamed clenching and grinding the teeth on stress. And indeed, I believe that all of us will clench and grind our teeth from time to time due to emotional stress. It's in the Bible, for crying out loud. This has been around a long time. However, here's what I tell my patients now. We've blamed it on emotional stress for years and years. Many people, all of us, will clench and grind our teeth from time to time. But now Research for the past 30 plus years has shown that some people may clench or grind their teeth or just posture their jaw to try to protect their airway so they don't suffocate to death, or what I refer to as the stress of suffocating to death. And what about in kids? See, we don't blame bruxism in kids on stress, do we? Well, except for this kid, if you're old enough to remember those E-Trade commercials, that guy was stressed all the time. But normally we just say with kids, well, they just do. And then they will grow out of it. And even that makes sense from a airway perspective, but we won't talk about that right now. So just some things here with kiddos is there seems to be a lot of correlation between poor school performance, hyperactivity, bedwetting, and tooth grinding. And all of those things are also associated with obstructive sleep apnea. In the second study there, all of the kids diagnosed with severe obstructive sleep apnea hypopnea syndrome presented snoring and bruxism. Something that I have found, and in the thousands of dentists that I've taught have found this, if you have a kid that you see in your practice that has evidence of bruxism, and mom or dad says that kid also snores, that kid has sleep apnea till proven otherwise. Now, I've got other stories. We'll talk at the end here about some other CE stuff we're doing. Then I'll tell you a story of my own kid when we do that, and he didn't snore and he didn't have bruxism. So I'm not saying they have to have those things, but I'm telling you, if you have a kid in your practice, evidence of bruxism, mom or dad said the kid snores, that kid's got sleep apnea. So what do? In these cases of kiddos, we take their tonsils out to treat the sleep apnea. Well, if there's a correlation between this apnea and bruxism thing, well, theoretically, if we take the tonsils and adenoids out in a kid, that should affect the bruxism. And that's what these studies show, amongst others, that after tonsil adenoidectomy, there's an important or a significant improvement in bruxism. Well, so what is a possible treatment for nocturnal bruxism that maybe we haven't taken advantage of yet? Well, maybe CPAP. How many of you put your bruxism patients on CPAP? Well, me neither, but if this paradigm was true, then this should work, right? And I've had the privilege of talking to sleep doctors and sleep technicians all over the country. And this is just a case study right here. But what this case study showed was there was a patient with really bad bruxism, and they put him on CPAP, and during the CPAP titration, a complete eradication of the tooth grinding events was observed. And I've talked to, like I say, sleep techs who this was their job. Nowadays, the CPAPs are auto sets, and actually, unfortunately, this has become more automated, but not necessarily better. But I would ask the sleep techs, hey, when you see people on a baseline study in the sleep lab, do they tend to have more bruxism events than when you put them on a CPAP machine? And they would always kind of think about it for a second. They'd go, you know what? You're right. I see less bruxism once we put them on CPAP. And I'm blessed to work with sleep doctors and sleep techs, and the sleep lab in Boise, Idaho, where I'm from, they will actually adjust CPAP pressure to reduction of bruxism. If they turn up the CPAP pressure and the patient's snoring's gone and their hypopneas are gone and their apneas are gone, but they're still grinding their teeth, they'll push up the pressure a little bit more and see if it makes a difference. And they tell me that a lot of times it does. Crazy, right? But Jamison, this is how we treat nocturnal bruxism. Do we actually treat bruxism? I don't think I need you to put that in the Q&A, do I? Because the answer is no, we don't treat bruxism. We protect the teeth. And we all know that. And I would propose to you that our patients don't know that. And why I say that is because as a guy who treats a lot of TMD patients, when the patient comes to me, they say, oh yeah, my dentist who referred me here, they gave me a night guard, but it didn't work. And I say, well, what do you mean it didn't work? And they go, well, I still clench and grind my teeth. And I say, well, right. It's kind of like your problem is banging your head against the wall and your dentist gave you a helmet. That's what we're doing. We're given tooth helmets. And then I'll usually say, so here, one of our goals is to try to figure out, why are you banging your head against the wall? Would you like to figure out why you're banging your head against the wall? Or should we just give you another helmet? And frankly, my female patients will say, well, I'd like to figure out why I'm banging my head against the wall. And my male patients typically just say, just give me another helmet, doc. Now, this study is celebrating right now its 20th anniversary. 20th anniversary. But I'll bet most of the people on this webinar have not heard of this before. Dr. Gilles Levine, University of Montreal, he was recently the dean, he's doing back in research now. Him and his group looked at a small group of people who had known sleep apnea, and they gave them all a flat plane upper guard. And what they found was that half of the people, the flat plane guard made their sleep apnea worse. They said use of an occlusal splint is associated with a risk of aggravation of respiratory disturbances. Whoa. Now, that's in 2004. In 2005, the American College of Prosthodontists said in their position statement, practitioners, meaning prosthodontists, should screen patients for OSA prior to fabricating a maxillary night guard. And they are quoting that study right here, saying the same thing, that use of a flat plane upper guard could make sleep apnea worse. Now, unless you're brand new or a dental student, you have experienced this. You have made people's sleep apnea worse with a night guard. And this is how it presented to you. It didn't present as the patient came in and said, hey doc, you made my sleep apnea worse. How it presented is the patient came in for recall or whatever, and you said, hey Jim, how's it going with that night guard we gave you last time? And Jim said, you know what, doc, I gotta be honest with you, no, I'm not wearing it. Why not? Is it uncomfortable or something? It's like, oh no, actually it feels fine, but it's the weirdest thing. I try to wear it to sleep and I wake up and it's in my hand. I wake up and I've thrown it across the room. I wake up and it's in my sheets. I just can't keep it in my mouth. Another patient, you say, well, how's it going, Diane, with that night guard? Well, doc, you know, I'm embarrassed to say this, but I can't wear it. Well, why not? Well, actually, my husband says it makes me snore. It makes me gag. Any of that ringing a bell? I'm sure it is for every one of you. So that is when we use an appliance and for some reason, it makes their jaw fall backwards. Something happens with that that's different than their normal occlusion, and it seems to block their airway. Now, on the other hand, you've all seen probably the opposite of this too, where you gave someone a guard, maybe they had a class 2, div 2, deep overbite, you put that guard in, and maybe that actually allowed their jaw to get out of its own way, so to speak. That's the person who came in and you said, hey, how's it going with the night guard, Bill? And Bill said, doc, you won't believe this. Ever since you gave me that night guard, my back pain's gone. And you said, yeah, I figured that would happen. You took credit for that one, didn't you? Okay, here's my point though. If we can make some people worse with a guard, because remember, when's this guard actually doing something? Well, it's only when their teeth touch. So some people that may position their jaw backwards. Some people it may allow them to posture their jaw forward easier. And that's going to be a difference. But the bottom line is, let's be careful with this. And in my practice, now again, you may do this differently, but in my practice, we don't fit a night guard until we've ruled out sleep apnea. So if CPAP will blow the airway open, and maybe that has something to do with bruxism, interestingly, well, what about these oral appliances that we use for the treatment of sleep apnea? Because that's basically head tilt, chin lift. So maybe these things should help with bruxism too. And so here's my airway looking down on it. Here you can kind of see the change in that hole with that oral appliance forward just a little bit. So huge change in all dimensions. So not just AP. So Dr. Levine, here's his name again, his group did stuff on this too. So they took 12 people, they had them spend 5 nights in the sleep lab, crazy. 1 night was just to get used to the weird experience. 1 night was baseline. 1 night was with a mandibular advancement device a little protruded. 1 night was with the mandibular advancement device more protruded. 1 night was with a flat plane night guard. What they found was that use of the mandibular advancement device, a little protruded or a lot protruded, reduced bruxism. They did a similar study using a boil and bite appliance. They found that a mandibular advancement device reduced bruxism. So let's talk quickly about screening your patients, and we'll be wrapped up here pretty quick. I wonder how many of you are aware that the American Dental Association has asked us as dentists to be screening our patients for sleep-related breathing disorders since the fall of 2017. Here is that, and you can find this online, but our role as dentists in sleep-related breathing disorders, and again, the ADA has asked us to do this since 2017. That should make these discussions with your patients a little easier, because what I say is, hey patient, you know what? The American Dental Association asked us decades and decades ago as dentists to screen our patients for possible cancer, oral cancer. And so every time you come in here, we do a head and neck cancer screening. We don't make a big deal about it, but we do that because we can catch things early that could literally save your life. As of 2017, we've had the American Dental Association ask us dentists to be screening our patients for sleep-related breathing disorders, sleep apnea, things like that. The reason they've asked us to do that is because there's things that we can pick up early that could literally save your life. Okay, so I make that connection between cancer, say that the ADA made me do it, so to speak. That's an easier way for you to have these conversations. And some of the things that we're looking for are stuff that you see in the mouth every day of your life. All of these things are, again, normal fare for you, and all of these things are risk factors for sleep apnea, actually, okay? Including perio. Were you aware that people with periodontal disease are more likely to have obstructive sleep apnea? In this study, a pretty good N there, 687 participants, they found that 17.5% of this random group of people had periodontitis, 46% of the random group of people had obstructive sleep apnea, but 60% of those with perio had obstructive sleep apnea. Okay, almost 15% more had obstructive sleep apnea if they had perio. Interesting. So again, this kind of a screening form we put together and stuff. We're going to talk in a minute about a course that we're putting together for the fall. We would go over this in more detail, but these are some of the things that you can be looking for. This down here is called a Mallampati class 3 or 4. If you can't see down their throat, then you might start asking questions. And let's talk very briefly, and then we'll wrap up here, about our role in the management of snoring and sleep apnea. And a lot of that, I know you think, is about these oral appliances. And indeed, this is an important part of it, is our oral appliance therapy, but a bigger part is kind of understanding the whole thing with sleep apnea and what is normal sleep and what is abnormal sleep and how does this affect this. But I know probably a lot of you are thinking, you know what's the best appliance, Jamison? And so let me actually just cut to the chase and just tell you what it is. There's 150 FDA approved oral appliances out there. Let me just cut to the chase and just tell you the best one, okay? You okay with that? So here it is. The best oral appliance on the market, the very, very best one, is the one the patient will actually use. Okay, that was probably disappointing, wasn't it? I bet you had your pen there ready to write down what the best oral appliance was out of the 150 FDA-approved appliances, and now I just ruined it for you. But this is the truth. The science of this field is pretty simple. We keep the jaw from falling backwards, or we bring it forward a little bit to open the airway. The art is figuring out what will the patient actually wear, because the best oral appliance on their nightstand or in their medicine cabinet is not effective at all. Okay, so hate to spoil it for you, there isn't one best one. There's one best one for that specific patient that's in front of you. All right, so in kind of conclusion here, oral appliances for snoring and sleep apnea cause or make TMJ problems worse, right? Well, maybe not. So this was a meta-analysis done by Jeff Okeson's group, and what they looked at was using mandibular advancement devices for obstructive sleep apnea, and if this caused people with TMJ problems to get worse. And reading this entire conclusion here, the meta-regression analysis showed that patients with pre-existing signs and symptoms of TMD do not experienced significant exacerbation of symptoms using the mandibular advancement device. The presence of TMD does not appear to be a routine contraindication for the use of mandibular advancement device for the management of OSA. Now, those of us in the field have known this for years, that these appliances do not cause TMJ problems to get worse. And so then that might beg the question, but are you actually saying, Jamison, saying that treatment of obstructive sleep apnea could help patients with temporomandibular disorders? And indeed, that is what I am saying. And that same group very, very recently published a study showing that. They took 40 patients, and 33 of these patients underwent treatment for their obstructive sleep apnea. Here's the cool thing about this study. Some of those were on CPAP. Some of them had surgery for their sleep apnea. Some of them had oral appliance therapy. All 33, as you can read here, all 33 who underwent treatment, their TMJ problem got better. The 7 who didn't undergo treatment for their sleep apnea, their TMJ problem did not get better. Now, this is what I see clinically. When I refer people who come to see me for a TMJ problem, and I think they might have sleep apnea, and I send them to my sleep doctor friends, and they get diagnosed with sleep apnea, and they get put on CPAP, often their TMJ problem gets better with no treatment directly associated with their TMJ problem. Interesting, huh? But Jamison, why don't we just Botox these patients? Okay, here's where I'm going to end. So I'm going to show you a little excerpt now of a show called The Doctors. And on this episode, they have a woman, and she's suffering from, now forgive the doctors here, because they're going to use the term TMJ over and over again. They mean temporomandibular disorders or TMJ disorders or TMJ disorder syndrome or whatever you want to call it, but they're going to say TMJ. So forgive them there. But I want you to see if the doctors maybe miss something in their diagnosis. And then if you have got questions, then you can put them in the Q&A and we'll spend the last few minutes answering your questions. But listen to the doctors here and see if they miss something in this patient's history.
Do you have a recurring headache, maybe jaw pain, or hear clicking sounds when you take a bite of food? If you do, you may have a disorder called TMJ. And here to fill us in on a possible solution is cosmetic surgeon Dr. Alex Rivkin, as well as Suzanne. And Suzanne suffers from TMJ. Welcome to you both.
Thank you.
Thank you.
Hello, welcome back.
Thanks. Pleasure to be here.
You know, and TMJ, either an acute or chronic inflammation of your temporomandibular joint, is such a common problem. Over 35 million people have this condition. Second leading cause of musculoskeletal problems, secondary to back pain.
Yeah, it's of 75% of people in the United States at some point in their lives are going to have symptoms of this syndrome.
I want you to take a look to see what goes on with TMJ problems. And for a lot of people, it starts with grinding of the teeth.
Why would anyone do that with their jaw, I wonder? Thrust it forward like that. Weird.
It has an effect on our jaw joint to cause difficulty opening your mouth, chewing, and pain. So what kind of symptoms were you having, Suzanne?
Well, I do a lot of clenching and thrusting of my jaw to breathe because I have sleep apnea. So for me, it just manifests in like throbbing pain right along here. I can't sleep. I wake up, completely like I haven't slept at all, and intense pain. Like it just radiates from right through this area up right to the temples and right the back of my neck. Everything gets pulled out of whack, and it's just, it's
a pretty
constant.
Debilitating condition.
It's very debilitating.
What kind of things did you try to make yourself feel better?
How long is the show? I've tried everything from acupuncture, antidepressants, chiropractic, where they stick like their fingers in your mouth and pull. I've done night guards with the dentist. I had my wisdom teeth pulled. I've had my sinuses cleaned out because they thought that might help with the breathing.
So a lot of the conventional TMJ treatments
Right.
that we hear so much about.
Right.
So, Dr. Rivkin, we've heard of Botox for wrinkles, for sweating, and we're hearing about more and more uses, but now you're using it for TMJ. How does this work?
When think
Huh. Did the doctors miss anything there in Suzanne's history? Literally the first words out of her mouth were, I do a lot of clenching and thrusting of my jaw to breathe because I have sleep apnea. Do you notice anything missing over here? There's nothing about sleep apnea. She did mention she had sinus surgery because they thought it might help with the breathing, but no one's ever had sinus surgery for sleep apnea. She doesn't mention anything about CPAP. She didn't talk about oral appliance for sleep apnea. She didn't talk about anything with sleep apnea. But yet, a few minutes later, she gets a bunch of Botox stuck in her masseters. And do you think this is the first time Suzanne's had this treatment? Obviously not. You wouldn't bring her on a nationwide show with a live studio audience if she never had this done before. So she gets it done, a few months go by, and then she gets her muscles back online, and next thing you know, she has pain because those muscles have been reduced by the Botox, and now she's recruiting motor units again, and then it hurts, so then she goes back to this guy and gets Botoxed up again. And you know why? It's because she looks like she looks, and not like one of these guys. If Suzanne would have been lucky enough to be a fat, older man, they wouldn't have missed her saying she had sleep apnea. But because our doctor colleagues are only looking for fat, old man for sleep apnea, she got missed. And here's the last thing I'll say about this, but I can definitively say that never in the history of planet Earth has anyone had a TMJ problem due to a Botox deficiency. Okay, and I will leave it there. So let's go ahead and answer some questions, or try anyway to answer
Hey,
some.
we probably have too many questions to get through, which I think is a good thing. If I can make one comment before we hit the questions.
Please.
Physicians, if a patient has difficult to control blood pressure at this point in time, they recommend a workup for sleep apnea, and it makes a tremendous difference. So it is
Thank
systemic, and there are lots of effects from it. But let's get to some of the questions. I'll see what we can do here. So I'm going to go back. The first one, we've been talking about occlusion. And they asked, so based on what you said about occlusion, how important is restoring fillings to proper occlusion?
I'm not sure that those two things correlate, except for the fact, so one of the principles is, so most of you know what I mean when I say occlusal neurotic. And that's somebody that thinks about their occlusion all the time. And I like to say that occlusal neurotics were not born, they were made. And what I mean by that is that someone who has all of a sudden become super duper concerned about how their teeth come together, they were made aware of their teeth and how they touch and things like that. So I think for the most part, the way we should be doing this as dentists is we take care of the occlusion and we think about it and we fuss about it, and our patients shouldn't ever think about it. So they should only think about lips together, teeth apart. So I think in general, yeah, I mean, we would like to not jack up their existing occlusion and what they're used to. So I guess I don't know if that's a very good answer to that question. I'm not sure I actually even understand the question, but I would say as a rule of thumb, we don't want to ignore occlusion. We don't want to screw up their occlusion. We want the patient to be able to continue to live their life without thinking about their occlusion.
Thank you. So I'm going to actually hand off to Dr. Mansdorf to continue with the questions. Okay. Dr. Mansdorf, the next question is the one that came in at 7:36.
Okay, let me go up to it. Just before we get to it, I just want to, first I'd like to thank you. It's been such a pleasure preparing for this lecture, this webinar with you. You've been such a pleasure to speak to, and your assistance in getting this off the board was invaluable. And then I thought it couldn't get better than that, but this webinar was even better than that.
Oh, thank you, Asher. I appreciate that.
So thank you very much. Okay, so the next question, and I might skip around, is what's the difference between clenching and grinding? You mentioned that clenching doesn't cause pain, but does grinding cause pain?
No, it was the other way around. So the difference between clenching is this is clenching straight down, grinding is grinding side to side or forward. And so as dentists, so our physician colleagues say it all as bruxism. So typically in the literature, you'll see bruxism. Occasionally, you'll see an article about clenching. As dentists, we tend to differentiate bruxism into lateral bruxism, anterior bruxism, so lateral side to side, anterior forward onto the front teeth, and then clenching. Clenching is straight down, no side to side movement. What I showed in that little, what I tried to show anyway, in that little experiential moment was if you clench your teeth as hard as you can't grind in any direction. So people who are grinders, lateral, bruxers, or anterior, they have to relax to a degree their elevator muscles. As such, and again, virtually every dentist on this webinar right now will recognize this, the people that you see with tooth wear rarely have muscle pain, rarely have joint pain. It's people with beautiful occlusions that are clenchers that will tend to have greater pain, and that's because they're able to recruit more motor units. By the way, Asher, I'm going to put this next slide up too, and then I'll stop the share. But I do want everybody to know, and maybe you or Lauren are going to talk about this, that we are going to do a full one-day course on TMJ and sleep apnea, TMJ disorders and sleep apnea. So I know that you all will be sending information out soon, but anyone who's interested in that can mark their calendars now for November 3rd. I'm really honored to be coming to Touro and to give a full day on these topics. But let's go ahead and continue with questions.
So first of all, thank you for putting that up, and I'd everyone to notice that it's a Sunday. It's very unusual to have a full day availability on Sunday, so please take note. I have a question here from Dr. Stephen Syrup, who's a mentor of mine and is in New York City and is also a member of the staff at Touro, and he asks, what percentage of sleep apnea patients have sleep bruxism with TMD symptoms?
I don't know that question. So I think there was a study done a while back on, what percentage of people with obstructive sleep apnea had bruxism. I would need to look that up. If you could email me, doctor, so that's my email, jamison@jamisonspencer.com. I can find that for you because I believe that is known of in general what percentage of people with obstructive sleep apnea also have bruxism. Something we don't think about a lot as dentists is bruxism is a sleep disorder. So it's listed as a sleep disorder with the other sleep disorders. But off the top of my head, I can't really tell you what the percent is.
Okay. You may have answered this already. Will you be discussing NICAR treatment? I believe you did. Or do you not believe in it? I think you answered that as well. If you do you recommend hard or soft? And that might be the answer. Your answer might have been the one that the patient will wear, I'm assuming.
No, that was different. So on the one the patient will use, that was about sleep apnea appliances specifically. So with regard to night guards, what I believe on that, and this is from a guy that has a limited practice, so everybody needs to understand that. So in my practice, and the doctors that work with me in my practice, if we have a patient with some level of temporomandibular disorder, one, they've almost always been given a night guard before they come to us in the first place. But let's say they hadn't, then we might give them a night guard. However, in our practice, much similar to that College of Prosthodontists position statement, we rule out sleep apnea prior to giving someone a night guard. And I encourage you to do that too. However, what does rule out mean? So in my practice, that actually means sending them to a sleep doctor for consideration of a sleep study. In your practice, it may just be screening them really well, asking them questions. Do you snore? Has your bed partner ever said you stop breathing when you sleep? Things like that. So I would hope that after this presentation, you just be more aware of, gosh, I wonder if this, and I promise you all are going to have patients that clench and grind their teeth, and it has nothing to do with sleep apnea, okay? Hopefully I've made that clear. I'm just saying that some people clench and grind their teeth to try to protect their airway. Some people. Those people will tell you, yes, I snore. Yes, I've been told I stop breathing when I sleep. Yes, I'm tired during the day. You can't see down their throat. All of these things will start lining up and go, aha, that makes sense. And then those are the people I'm telling you that if you treat their sleep apnea, sometimes their bruxism actually goes away, regardless of the treatment.
So the next is this all about OSA or also about CSA?
So central sleep apnea is a little bit different. So with central sleep apnea, it's your brain forgetting to tell you to breathe. And that does seem to be different. We don't seem to have, that's a good question, actually. We don't seem to have the same bruxism behavior with central sleep apnea. Now, here's the good thing, I guess it's a good thing, is I've never seen a patient with pure central sleep apnea. So it's central sleep apnea almost always exists in a world of obstructive sleep apnea. And almost always it will be vastly obstructive sleep apnea with some central sleep apnea. What our medical colleagues and us have found over the years is if you treat the obstructive sleep apnea, which is what we do with CPAP and oral appliance therapy, the central sleep apnea gets better. CPAP doesn't treat central sleep apnea either. So if you had someone that actually their problem was central sleep apnea, their current treatment would be a ventilator.
Lloyd, is there evidence to explain why so many special needs patients brux?
Particularly Down syndrome patients. Down syndrome patients have macroglossia. They tend to be retrognathic. They also tend to be thick. So a huge, and I wish I knew the number, but probably a simple Google will find you this, a huge percentage of people with Down syndrome have sleep apnea. This is very well known. The difficulty becomes people with Down syndrome may or may not lend themselves to wearing CPAP. I've treated multiple people with Down syndrome over the years with oral appliance therapy. They tend to do pretty well. I've also treated what we call combination therapy, where we do an oral appliance in conjunction with their CPAP to reduce the pressures of the CPAP. That's a lot for someone, especially with special needs, to handle, but that is part of the problem. And then, of course, we have some of the Pierre-Robin syndrome and stuff like that. That's clearly anatomical, and that's well known too that those people have sleep apnea.
Is it okay if we do 2 or 3 more, or?
I'm good.
Okay. If a child has tonsillar hypertrophy not due to recurring strep, etc., is it usually due to mouth breathing? Is it commonly found in children with apnea?
So starting with the apnea part first. So yes, hypertrophy of the tonsils is highly correlated with sleep apnea in children. However, if you have a kid and you suspect sleep apnea, for example, let's say you go back to your practice and you get that kid with evidence of bruxism and they snore, and so mom or dad says the kid snores too, and you look in their mouth and their tonsils don't look big to you. If that kid gets a sleep study and is found to have sleep apnea, they'll still take the tonsils and adenoids out. So it's not about the size of the tonsils and adenoids, although sometimes it is, but even if they seem normal, they will still take out the tonsils and adenoids because it will have an anatomic difference that's a big deal right this second. And with kiddos, one of the phrases I like to say is, how many nights without proper oxygenation of the developing brain are too many for your child or grandchild? So with kids, we don't like to screw around. We try to go straight to the area here, see what we can do, and then you monitor them, and then maybe down the road comes in palatal expansion, myofunctional therapy, all that sort of stuff. Does that help on that question? I think it did.
So this is anonymous speaking again. This is not me. I have a patient with a mandibular advancement device which helps her OSA, but now her jaw has actually advanced. Right. And she has become class 3 due to the device and is constantly trying to push back her jaw. What can help with this?
Yeah. So come to our course in November and I'll teach you how to avoid that. So that's a common side effect of oral appliance therapy, not purely done by dentists who don't know what they're doing per se, because our patients will have posterior open bites develop too. However, there are things that we can do. We make a little anterior jig that I have coined an anterior reprogrammer, and that word I made up to be the opposite of a deprogrammer. So what we give our patients is this little custom-made anterior jig that they use in the morning to try to get their jaw back to normal. My wife uses one of those to get her bite back, and she struggles. It's difficult for her to get her bite to go back. Me, on the other hand, I wear an oral appliance. My bite goes back together normal before lunch. So, but I'll talk about that at the bigger meeting of how to avoid those sorts of side effects. If they already have it, it's tough to reverse it, but you can.
Some patients complain of pain after wearing an occlusal night guard. Why is that? Is that because the guard was too thick?
Not necessarily, and it would depend on what you mean by pain. So they could have pain in their teeth, which could come from them smacking their teeth against it, and particularly with an NTI style appliance where they are only hitting in one spot, people will complain of pain in their lower teeth, and that tells you, hey, you're actually putting some pressure on this thing. So it would depend on what you mean by pain. If you're talking about muscular pain, then it could be maybe it's a little thick. That could be, we had that question before about the freeway space. Yes, if you make a really thick guard, that could do it. I'm not a big believer necessarily that the soft guards make people grind their teeth. Our oral surgery colleagues love squishy night guards. Why they like squishy night guards is because they require no skill to fit and no follow-up. And I don't mean that as a slam to oral surgeons. I don't mean it that way. But it's just easy to give them and goodbye. There's nothing I need to do forever. So harder night guards are more teeth-like. But I think maybe that thickness is kind of a big deal. With sleep appliances too, I try to have the sleep appliances we give our patients at the lowest vertical that it can possibly be made.
When would you determine to use an OSA mandibular splint versus CPAP, and can they be used at the same time?
Yeah, so I covered that kind of with our special needs patient that we will do combination therapy where we do an oral appliance in conjunction with CPAP. The vast majority of patients that we will see as dentists are either one, CPAP failures, that's the biggest group. So they've tried CPAP and they can't use it. So then they end up with us. Or nowadays, oral appliance therapy, since the pandemic, has gotten much more respect as a first-line treatment. Most insurance companies do not require you to fail CPAP to try oral appliance therapy, including Medicare. So since the pandemic, there's a lot more sleep doctors now who are, especially with mild or moderate sleep apnea, they will tell their patient, here's your options, oral appliance or CPAP. Which one do you think you're more likely to use?
Okay, so I think that'll bring the evening to a close. I just want just a couple of closing comments. First, I want to thank Mr. Steven Zelig for all the work he did behind the scenes and making sure that this evening was successful. So thank you, Mr. Zelig. I want to thank Dr. Wax and Dr. Levy for everything that they did to bring this about. If anybody has ever had the chance to listen to Spencer Jamison lectures, especially his study club stuff, this is just a small dose of the phenomenal material that he has available at his fingertips. And I can guarantee you one thing, that if you come to the lecture, the 6-hour lecture, the one thing you will not do is fall asleep. So thank you very much for a phenomenal evening. Thank you, Dr. Wax. Thank you, Mr. Zelig. Thank you, Dr. Levy. And most of all, thank you, Doctor. So just phenomenal. Thank you.
We'll see you, I hope, in November.
Yes,
Thanks,
thank
Dr.
you.
Spencer. We appreciate it. Good to see
My
everybody
pleasure.
here.
Take care.
Have a good evening, folks. Well,
I gotta tell you, I mean, at the end, there were 110 people.
103. We're
Okay.
5 of them, and some people are on 2 devices. But it is 8:19, and we had 103 states.
He's such a lovely man to deal with, and the material was so good.
No, I think it was great attendance. People stayed. I think it was a great lead-in, and I think people got stuff out of it. And certainly, there'll be people who want to hear more from him.
And Mr. Zelig, Stephen, I got to tell you, the amount of work that you did and in making this happen, I don't really know how to adequately say thank you, so I'm just going to say thank you.
Well, you're all welcome. There's a lot more work to be done now to put together this November program in person, but it was remarkable that we had as many people as we had, and that they all stayed even 10, 15, 20 minutes past the hour. Is a very good sign. Very good sign.
We don't see that often, Stephen, because you and I are on all of these and
Yeah.
special needs and everything else. And this was
Right.
probably one of the best attended things we've seen,
Yeah.
and they all stay. Thank you both. We got a lot to look forward to, I think, and we'll
Yes, thank you, thank
vote
you.
tomorrow. Thanks, guys. Have a good
Have a
night.
good evening.
And Stephen, thanks for taking your evening time to help us out. We appreciate it.
Pleasure, always. All right, time to watch the convention now, right?
Yeah, there we go.
Yeah.
All right. Thanks.
See you all tomorrow.
Yep. Great job, Steve. Thanks.
Sure.